the second episode of our second season in the Voices Project Dialogue series. I'm Rohit Sehgal, Chief Strategist. The Voices Project is a neutral, independent, non-profit platform that aims to produce deep insights and knowledge on public health issues in Asia Pacific, rooted in local circumstances, experiences, and divergences. By empowering voices, what we seek is to expand our collective understanding of how public healthcare issues take form in the region's context. Our objective this season is to lay the foundations for a regional understanding of a framework for the role of technology in life sciences. It's a critical component of the UN agency's Sustainable Development Goals, particularly SDG 17. It has an entire chapter on that. So for our listeners who are interested, you should definitely have a good read of that. It's a critical component and possibly a horizontal for how sustainable health for the future is going to take place. And by doing so, we aim to develop region-specific consensus that can be leveraged by policymakers, healthcare professionals, and actors in the private sector to better facilitate the development and rollout of medtech in Asia. And it's by taking a continental look rather than an isolated, localized approach that we think makes a big difference. Ultimately, developing broader collaboration amongst policymakers, agenda setters that complement and build upon existing initiatives. I'm so delighted to be joined today by two very special guests, Rajiv Variani, Senior Program Consultant with the Ministry of Health, Ontario, where he's responsible to plan, lead, and manage the Ontario Health Data Platform Program, an extremely challenging and I'm sure exciting role. And Dr. Karen Priyadarshini, Worldwide Lead for Health and Life Sciences, JPAC at Microsoft. Welcome to you both. As a quick introduction, I suppose it's always great for our listeners to understand a little bit about our guests and what their backgrounds are and what makes them tick is my favorite question. Rajiv, why don't I start with you?
Sure. Thanks, Rohit. As you briefly introduced me, I am currently a senior program consultant with the Ontario Ministry of Health here in Canada. So I'm managing the portfolio, which is the Ontario Health Data Platform, and my responsibilities include planning as well as managing the overall portfolio. For me, healthcare is really personal. For me as a patient's caregiver, so I have taken care of my parents' health for over 10 years, and that experience has helped me gain a lot of empathy and understanding of the nuances and the gaps within the healthcare sector, especially in the Asia market. My work also brought me very closer to the healthcare sector because I have worked in India, Malaysia, Singapore, as well as now in Canada, all through in the medtech and life sciences and healthcare technology sector. And that's where I have a decent understanding of the various different landscapes, how the services and the health system plays out, and what are the key challenges and what are the key opportunities for us to look forward to. So that's in a nutshell about me.
Thanks, Rajiv. Karen?
Yeah, thanks. Thanks so much, Rohit. So good morning and good afternoon to everybody. So I'm Karen. I lead the healthcare industry vertical at Microsoft for JPAC. And that involves working with providers, payers, as well as medtech as part of my daily work. What we help to do is to help digitally transform our clients in their journey so that we can look at more equitable, better patient outcomes. The other one I wanted to share was also that at Microsoft and with our health industry partners, we strive to achieve the goal of better health globally. And this is by offering people first solutions to empower organizations, patients, and care providers. And if you look at our mission as well, the mission is more towards empowering our clients and organizations as well. And one of the interesting things that we did a few years ago during the pandemic time was to launch the Microsoft Cloud for Healthcare. And it's very interesting because though there are many cloud capabilities, what we are trying to do is to equip our clients with capabilities to the Microsoft Cloud for Healthcare to actually manage health data at scale and make it easier for healthcare organizations to improve their own patient experience, be able to coordinate care among different stakeholders and still have operational efficiency. But at the same time, because this involves data which comes with its own challenges, be able to help support security, compliance, at the same time, interoperability of health data. And I'm sure we're going to be hearing more of that today.
Thanks, Karan, for that. In fact, that's a great segue into what the topic for this episode is going to try and gravitate around, and that's around personalized health. Personalized health, for listeners, is something within the health forum that's been discussed and debated for a long while now. It was always felt that either technology needed to play catch up, or perhaps health policies themselves needed to become a bit more broad-based in their outlook, and it'll be more inclusive on how technology and the role of technology augmentation, and I think Karan just outlined a few things there, would actually work. And the reason why we have Rajiv and Karan today is actually we can get a really interesting set of perspectives, one coming from an area and domain experience of technology-driven solutions in health, and the other right at the forefront, thinking about where different policies are now going to take place in a country like Canada, which is being held up as a best case practice on many, many levels. And there's many areas of cross-learning that Asia can also pick up from that. So looking forward to, I think, some very interesting thoughts and concepts. Now, I guess the good place to start is that today's world is obviously very different from not just 2.5, 3 years ago, but even, as some say, even 5 or 6 years ago. Various different policies were taking shape. The disruption came along, of course. Some called it a blessing in disguise for health policy and technology inclusion. What would be your takeaways in terms of how things have possibly changed in terms of, well, health behaviors is one thing, and one's relationship with health services. Rajiv, maybe I start with you on that, because I think there's some very interesting perspectives you might bring there.
Sure. Yeah. So Rohit, I think that's a very important topic that you're bringing right now. Let's go 3 years back. Imagine we are in a country like Singapore, we are in a city, New Delhi, or any other part of the world, right? And one is not feeling well and needs to go to a clinician. I think 95% of the time it would be going in person to a clinic or going in person to a hospital. Now, what the pandemic has done is pandemic has transformed the world around us with the crowding of hospital beds. There was rapid exhaustion of the medical staff. We saw a clear pivot and healthcare moving outside of the hospital. There were newer care delivery models that were formed, virtual care, home care, there was telehealth and so on and so forth. And what that led to us consumers starting to demand a new care delivery model at alternate sites. I think not only that, the consumers are also demanding seamless experience. I think that's because of the other non-traditional sectors also providing a very, very, very good seamless experience as far as their services. For healthcare as well, consumers are demanding seamless experience. An example would be, I want to schedule an appointment very quickly. I want to see my medical records. I don't want to wait for a clinician to provide me an appointment after 3 weeks. So that's the kind of experience that I'm talking about. Now, with that said, I certainly see a relationship with healthcare services change. Obviously, there will be more technology entrenchment that will lead to lesser physician loyalty. I would say, let me take a service with a physician who's giving me an appointment in the next 1 hour as compared to somebody whom I've been going after, say, a week. What will that lead to is primary care physicians as well as other clinicians will start facing that competition, and they will be driven to provide a lot more as compared to what they're doing right now. And the third thing is more ecosystem-based providers, like you have MyDoc in Singapore, you have Practo in India, you have a few more service providers as part of the ecosystem. They would play a larger role in providing services with regards to health as compared to individual siloed clinicians. So that's how I see the trend shaping. And to enable these trends, I'm thinking, and I'm sure that the public sector, the government, the payers, as well as other partners will start building out more policies, more reimbursement model, and playing their part to make this enablement. So that's how I see it.
I think that's a really interesting outline. I mean, one looks at it as almost like a two-sided perspective. The first is the benefits that personalized health obviously brings to the physicality of patients having to be within a certain bricks and mortar environment. But what's the reaction, or what would be, I guess, some of the issues that the health service providers themselves face? Karen, I think we touched upon this in the last episode, that how does technology and that disruption affect the health service providers themselves, and are they ways that are maybe technologies improving that, maybe allowing for there to be a bit more of a bridging between the two?
Yeah, so Rohit, thanks so much. This is actually a very, very important part of the whole game, right? But before we get into how, what are some of the changes that we see and how they are being impacted, I just want to outline, adding to what was said earlier as well, that there's been the last 3 to 5 years, there's been so many changes, and the whole fabric of healthcare, if I can say, has changed. And in my personal view, I think the biggest acceleration, there are a few of them that I'd love to outline and then see how they have impacted this whole relationship, not just on the providers, but between providers and payers. And as was shared earlier as well, the ecosystem play that is coming about. So I think the biggest acceleration has been also in the model of healthcare, right? Because earlier, like what we just shared, that if somebody was sick, one would either go to the hospital or do a telemed. But now we find that care is moving from hospitals to community centers. So instead of going all the way to the hospital, you might want to use telemedicine, and take care of yourself at home. And because of this, a growing number of physicians are also overcoming the barriers of time and space to deliver the right care to patients where they need it, without the patients ever having to leave the comfort of their home. And this is not just within a country, but cross country. And since I speak from Singapore and we have a lot of medical tourism, you do see, Indonesian patients who come to Singapore and then go back. The doctor is able to kind of reach out to them on a regular basis as well. That's one. So I would say, in a way, remote monitoring through smart devices, that has been a game changer as well, because now doctors are not just looking at data that's coming in a periodic 1 to 3 months, but they are looking at continuous data, and that kind of also changes the way you can drive patient outcomes as well. And this is where your IoT, IOMT, all those kind of things come into play. And I think all along in our conversation right now, we've been talking about data and AI, again, have helped in converging the providers and payers, right? So payers are looking at reducing the costs and providers are looking at giving the best care. So how do we kind of use data and AI to merge, to bring these two groups together? Which we haven't seen before, but we do see payers now stepping in a very big way into the whole healthcare scene. And then, of course, we also see non-healthcare players like, tech companies like Microsoft. We also have retail firms like Walgreens Boots. We have banks like, some of the major banks like HSBC as well, bringing in solutions to bridge this gap in healthcare. So coming back to your question, I think that when you talk about the impact, I think there are a few. One, of course, is in terms of the technology capabilities that are being built, but also the relationship, which means how do the number of players and types of players that are coming into this whole healthcare game, which are not just healthcare players. And thirdly, I think which is super interesting is that hospitals are going to change. When I say hospitals are going to change, it's not just the system, but the structure, the way they are built, the smart hospitals, in a way that they're going to be the care, the last mile care or the last end care, right? Care is going to be taken care of at your community centers with your general physicians who are closer to you. And that totally changes the whole model in which healthcare is being developed. And so I think that would impact the economic models. It would impact the way care is given. But all along, as we mentioned earlier, patient is becoming demanding, and patient is the one who's going to be in the center and be benefited. So I think these are very interesting times, and things are kind of shaking up, if I can say a bit.
Now, electronic health records, clearly an essential part of solving health services. There's the struggle with patient load, the time, the costs. There's still countries, and many countries, that are still struggling in converting the analog manual method of managing health records and converting that into something which is more easily accessible. For listeners who perhaps aren't too aware of EHRs, that's the electronic health record system that many governments are now prioritizing as a way to enable management of disease and access to care and so on. But there's things that used to be talked about with AHRs, such as privacy issues, or the necessary resourcing and the training and the infrastructure. Rajiv, how are EHRs in, let's say, in the Canadian context, perhaps working or coming through this? And honestly speaking, is privacy still an issue, or is that just something which, is sort of old memories still coming through?
No, sure. So at a broad level, right? So you asked me two questions. One is, how is EHR adoption and transformation, especially in our market here, and then whether privacy is still a barrier or an issue. So I'll address the first one first. So when it comes to EHR, I think the adoption of EHR in our market has been I would say 7 on 10 at this point, especially in a few provinces which are way ahead as compared to the other ones. So we have 10 provinces, of which three or four have been much ahead of the curve. And one of the key themes when it comes to the motivation and the reasoning behind adoption of EHR and digital health, subsequent digital health technologies, is that there are healthcare organizations where the patients start managing their treatment, their care, and their overall rehabilitation. And while the patients are moving from one facility to another, there are integration issues, there are gaps in care where they fall into the crack, and that leads to further issues. So that has been a challenge. Like any other market, we are also facing that challenge where you have healthcare systems where there are gaps, and integration of care is something that is a high priority for the various provincial governments as well as the federal government. So when it comes to integration of care, EHR plays a huge role to allow that integration of care from a perspective that allows the patient data to flow freely, that allows the clinician in the respective organization to have access to the patient health information, and it also allows the patient to have access to their individual records as well as their overall data points. So at this point, I would say there is a lot of push, a lot of focus on bringing that push around adoption of EHRs as well as digital health records. Now, when it comes to the privacy, right? Now privacy is again a very broad topic. It depends upon the use case that we are speaking about. Now, for example, if the data, which is a patient private data, now if it is only relevant for the specific care for a patient, and it is only considered for the health information custodians, which is the hospital, the GPs, or any of the long-term care site. So it is usually assumed implied consent to collect, store, as well as share the information. So it is the circle of care. So in that particular use case, I don't see privacy as an issue, although there needs to be a governance. But when it comes to usage of patient private data, from potential of utilizing those large health data sets for creating certain tools, AI models, or related capabilities where the information will be utilized for maybe certain commercial purpose, certain patient care purpose, in that case, there needs to be a clear model, clear reasoning behind why that data set is being used, why what is the leverage of patient data privacy that has been implemented. So obviously there is a lot of talk about the patient data privacy, and here is where governance plays a big role to enable these use cases, right? So patient data privacy is an issue, but it depends upon the use case, and governance plays a big important role to enable those use cases.
Karen, let me spin that question slightly differently for you.
Yeah.
I think the way that you referred to it earlier, that the approach would be primary care, community level care, being almost at the front line, and the last mile coming towards where the specialist care, et cetera, needs to be, which makes tremendous sense. EHR is therefore, as Rajiv just outlined, from a governance perspective, would that struggle in terms of just the complexity of the various different infrastructures? Or in fact, is that part of the solution, actually being able to bridge all of these different care points together?
Yeah, so so that's a very nice way to spin that question, Rohit. The answer is the second, yes. So as Rajiv very beautifully outlined the problems, I think one of the reasons, of course, these communities will not go away, right? Your primary, secondary, tertiary, they're going to be there. And EHR, I probably want to take a slightly different angle. So EMR, EHR, if you look at, let's say about 15 years ago or 10 years ago, they were the whole point of truth. What that means is, if you talk about a person's health, all you need to do is to look at the health record, right? And it's even better, I'm sure the same, Rajiv, in Canada, but in Singapore, the day you're born, you start getting into the EMR right from your vaccination, date of birth, right till the day you die. So it's a very wholesome, complete record. But then come COVID, and even before COVID, there were rumblings and mumblings, right? And what began is this whole interesting journey on IoT and IOMT, where you started not just getting data every 3 months, but you're getting data points, 5 to 6 data points every day. Now, for a diabetic patient, this is a boon. For a cancer patient, this is a boon. For any other disease, blood pressure, I want to know whether it's high or low, and I don't have the time to keep measuring with the Omicron meter. So these smart wearables have really revolutionized health. Now you have on one end your big bulky mammoth EMR, and the other side you have this nimble, agile IoT, IOMT, and somewhere the two twain have to meet, right? And this is where, as what Rajiv beautifully outlined, we're looking at interoperability, right? How do you bring these data sets together? Because if you begin to integrate them, let me tell you, it was going to take you not less than a decade to integrate these pieces. So this is where, tech firms have come together to sign what is called the FHIR standards, where we call fast healthcare interoperability resources, where that is FHIR, we pronounce it as FHIR, where we're saying, how can each of these systems talk to each other? So just to give you an example, Microsoft has got Teams, which we use for telemedicine and for calls. And the way we are looking at interoperability is that when a doctor is doing a telemed call, he or she can see the EMR, he or she can look at the same screen, be able to look at the DICOM images, your CT scan, your x-rays, at the same time, be also any lab reports that come in, and any smart wearable data, your continuous monitoring data. But again, this is a lot of information, and doctors just have 7 to 15 minutes, and then superimpose that with AI and ML. So it kind of crunches all that data together, gives broad insights to lead the doctor. Hey, these could be some of the things that you might want to look at. So that's where this whole interoperability comes in, because you're never, ever going to be able to have a seamless system. The simple reason is the complexity of healthcare. It's not like your banking, it's not like retail. Human body itself is so complex, and the systems are so complex. You just have to kind of look at it. It's so beautifully made that you're never going to have one beautiful system and say, oh, I've got to get everything in. So the only way is to be interoperable. And I think, Rajiv, you mentioned this in the beginning as the ecosystem, right? So this is where we are saying, how do we get all this data from the different ecosystem players in a very interoperable way? And you might wonder, what's the end goal of doing all this, mumbo jumbo? The end goal is better patient outcomes, being able to coordinate care so there are fewer errors. I'm not sure, long ago, I read one of these articles that 67% of deaths that happen in the operating theater is not because of the disease, but because of error. So that's where you're looking at care coordination, you're looking at minimizing errors. You're able to kind of remove the ambiguity out of the whole thing by being able to plan out. Simple example is, I'm digressing here, but simple example is the HoloLens that Microsoft has given, where it's like a flight simulator. Even before the actual operation takes place, you're able to pre-plan the whole thing. So there's no ambiguity, there's no, surprises that await you. So that's where I think is the way to go, be able to, and also medical devices, not to forget. So is there a plug and play? Hospitals, sometimes doctors complain, I have a GE system, I have a Philips system, I have a Siemens system. Oh, kind of getting all this together is a nightmare. So that is where I think the key is interoperability. How can I use APIs to just plug and play, irrespective of what device I use, right? So I think that's where the push should be. But then, of course, this whole question that you asked about, data privacy, I think you said data privacy, data confidentiality, because data is now going to grow exponentially. You weren't able to solve the problem when we were at EMR, EHR. Now it's 10 times more data that you're looking at. And I think I agree with Rajiv when he said that, it depends on the use case. Now that becomes a bit complex because you have so many countries and you tell them, oh, tell me what use case it is and then I'll decide. So what at Microsoft, what we normally push forward is we say, look at your data and classify that data. Now, what does that mean? Some data in some countries, especially in Asian, like your EMR core medical records are sacrosanct. Oh, that is something that you have to really keep private because you don't want your employers looking at it. You don't want your payers looking. Understandable. But there are so many layers of data. When you look at IoT, IOMT data, you're looking at footsteps data. You're looking at sleep data. How long do you sleep? There are a lot of other parameters which are not so critical. So can I kind of classify the level of sensitivity to a slightly different level where we're able to take this data to the cloud? Of course, it's all anonymized. You are never be able to identify, oh, this data belongs to Rajiv, this belongs to Rohit. No. In the cloud, all patient data is anonymized. But having said that, these kind of data can be moved to the cloud and you can do the analytics, which is what we really have to do. We have to take this data, not just collect it, which is what we're doing now, but be able to make sense of it so that you give it back to the patient who's contributing that data, right? So that's the whole aim. But right now, I think we're holding a lot of data and saying, oh, this is very private. This you cannot share, right? But there are layers of that you can share and give back to the patient. A simple thing like patient screening, right? We all go for corporate screenings and things like that. That data, you can build an AI model to say, hey, what's your risk of a cardiac attack? We worked with Apollo Hospital. They have a beautiful cardiac risk score. You don't have to do anything much. When you come in for your health screening, the model will run on that data. Health screening, do you smoke? Do you drink? Do you dance? Do you do this? All that sort of a thing. And then use that to just assess the risk of cardiac failure, because people now have heart attacks in their 40s, 30s, 20s, even in less than 20. So this is what I feel has to be the knit in the healthcare. How do you get different players to come and work together in an interoperable way? At the same time, maintain privacy and compliance for sure. But there are so many technologies that are now available. We just have to open our eyes to look at it. One of the things I want to just close by saying is we recently launched the Azure Health Data Services. You can actually look at it where what we're saying is give tools in the hands of hospitals, give the tools in the hands of government and regulators so that you can say, hey, I want to make my data anonymous. Okay, here's the one. I want to bring in my DICOM. So we have an API for DICOM images. Whatever be your system, EMR system, you can pull in your DICOM images with that API. So APIs are going to be the way that we're going to go forward with.
Rajiv, I know you're going to have to want to comment to that because I think that's tremendously close to where you are. But again, let me now spin a slightly different approach back to you, Rajiv, exactly where Karen was just coming from. That is it easier said than done in the terms of public and private competition? Many say is holding back this democratization of one's health, right? We talk about, sometimes is the private health side the leading in innovations. My own personal opinions might disagree to that. I think there's tremendous effort and work coming out from the public health, but should there even be this sort of two sides of the coin? And do you see, I guess, in the way that Karen just outlined, the various different approaches that are quite possible now, that is public and private sort of the obstacle in this? And should there be incentivizations, et cetera, being put into place?
So Rohit, again, right, I would just want to again rephrase the word competition between public and private, because I'm in a market which is fully public, right? I was in a market previously which was mostly in Asia, Singapore, Malaysia, as well as India, which was, you had public system working in parallel with the private system, and I think they had their roles to play. So that's how I see it. Now, from my perspective, there are initiatives, integration standards, regulations, incentives already in place for organizations to share the data sets between each other. But why the progress is slow is because due to there's so many reasons, right? It could be competition, it could be lack of data sharing agreements, it could be lack of technologies. Kevin just mentioned FHIR standards and your API-based integration would be more. But at this point, there are many markets where you don't have the digital health tools and technologies which are able to share information with each other. So it could be that kind of a challenge that we are grappling with as well. So here is, again, I mentioned this earlier, here is where I see a different trend, which is going to shape when it comes to democratization of the patient's health information to provide that patient with personalized care, which will be an alternate care setting. Now, I mentioned this previously as well, where I strongly see an emergence of health ecosystems which will be based on a technology infrastructure, and this will be really, really successful in creating that ecosystem environment for a patient to seek care. Now, I'll give you an example. Let's take a Practo or Ping and Good Doctor, or let's take HelloDoc from Indonesia. Now the platform is providing a primary care physician, they're providing a lab, they're providing a delivery of the medication to the patient's place of residence or preferred place of acceptance of medication. They're also providing, to an extent, a transportation service, because they have partnered with those ecosystem providers. And that's how I see an exchange of information for providing these care points. And these partners will start exchanging the patient information and form a layer. That is where most of the big data analytics, most of the tools will be built to even more personalize the care for a particular patient in their own private setting. So that's how I see it. And that's where more personalized experience to consumers will start shaping up. We are seeing, if you see the numbers, excess of 300 million for Practo in terms of usage. I would say even more for the China-based Ping and Good Doctor and others as well. So that's the kind of a experience, and that's the kind of a user base that these platforms are providing. And I see a clear direction in which that these providers might play a much more bigger game in exchanging all the information and then providing that layer of a personalized experience to the consumers. Now, here is where, as a public sector associate, the way I see is that the governments and the payers and the other partners who are enabling that system have to play a much larger role to build those policies, to build those enabling environment, because this is the model which I see really coming forward. And I think for the partners, they have to come together, align on the common goals, align on the objective from a public healthcare setting, and start working on those various enabling environment attributes. So that's my point of view on this particular aspect.
I always think in my head that there must be an insurance CEO waking up in the middle of the night in a cold sweat saying, personalized health, oh no, how are we going to manage this? I mean, this entire discussion, and hopefully our listeners have been keeping up with the variety of opportunities, seem to outweigh clearly the challenges. But how will, let's say, payers, insurers particularly, manage or keep up with the pace of this? We've talked about data in seconds. We've talked about the multitude of almost forming a full AI sequence of where health projections and innovations can be, managing it in and out of the hospital. How would insurers keep up with the innovation in technology in ensuring that they still have, I guess, skin in the game? I mean, any thoughts to that? Anyone?
Yeah, happy to take that, Rohit. So as Rajiv has been saying all along, right? I love the fact that he, sticks to the health ecosystem. I really like that because he's right that is where you're going to have that patient experience. And so in this whole ecosystem, I think the payers are somebody who are the smarter ones. And payers, there are two types. One is the public payers, which is like the government, and then you have the private payers like your typical insurance companies. So I would say that both have woken up because they realize that even before others that, hey, this population is going to be aging and I'm going to have a greater payout as the world progresses. I need to assess my risk. I need to build my models, not like my traditional models, but I need to have models that address specific issues. Like, typical example was COVID, right? So COVID, nobody ever covered. Communicable diseases were never covered under insurance. But now you see suddenly you have, even for your ART tests, you have insurance coverage, right? Reimbursement. So I think payers are playing a beautiful role, and I'd probably talk a little bit about both private and public. So if you look at private payers, as I shared earlier as well, Rohit, that they're coming in a space to reduce the payout. They're looking at preventive care. They're looking at wellness from the health perspective, right? How do I stop somebody from even getting into that funnel of sickness? How do I kind of, preempt them? Are there nudges I can give them? Are there incentives? To some of the private payers, you will see if you walk 10,000 steps, then they reward you with a $5 coupon or this, then there's competition. So they try the level best to kind of keep the individuals based on each, like what Rajiv said, their personal patient's experience. They want to keep them out of that, right? So that's one. The second is, of course, with the provider. Their relationship with the provider is very close. How do I ensure lesser fraud? How do I lower the cost of care, right? So a fever could be treated at $50, can be treated at $500. How do I use data to find these outliers? Which are the doctors who are prescribing more than is required? A very interesting example, right? I don't know, Rajiv, if you'll agree, and I don't know how it is in Canada, but when I came to Singapore about 10, 12 years ago, you have a stomach upset, they will give you like a tablet or an antacid and you're gone. But now I think a few weeks ago, I took my son and I was amazed. There are like 5 medication. You have for the stomach upset, then you have an antacid, you have a charcoal, and you have some other fever, and then this you take on one day, this you take on the third day. So the billing increases and you end up with a double amount of money. So this is where I think payers come in the traditional way and say, what are the benchmarks that we would like to lay out? And we want to understand, why is the cost far beyond that? Of course, there are pluses and minuses because sometimes each case is not the same. So you might need, and that's where care can be insufficient if the payers take that stand. So I would say private payers are stepping up. And they're also, like in Japan, you have an amazing public payer system, right? But there are gaps. They won't do this. They won't do health screening. They won't do care of childbirth. So this is where private payers are sniffing and saying, are there loopholes that we can plug in, So that's one area. Then if you look at public payers, especially during this whole COVID time, right? Rajiv, I don't know about the Canada numbers, but in Singapore, government actually gave payouts. They said, depending on your economic status, you will get a relief. They call it as a relief. In my eyes, I look at it as insurance reimbursement. It's like, okay, you're in the dumps. Here's a bit of relief I'm giving you. So governments realize that in their not just health, but other conditions as well, they will have to give out these payouts, right? So how about including them into the whole social insurance package? And
Yes.
that's where you'll be surprised that I think the last just 2.5, 3 years, we've been talking to a lot of governments on how do I, find a way to manage my costs, because it's going to increase. And now, thanks to COVID, I'm going to deal with communicable diseases as well. I thought aging was the only problem. Now I have these other burdens, and they say every 6 to 7 years, there's going to be a new virus coming out. So I think public payers are now stepping up. Their aim is to reduce fraud, be able to control costs. Private payers are saying, where is the incentive that I can top up, or I can go in areas where public payers would dare not intervene and kind of, capture use cases over there. So I think it's an interesting game where in the gaps that, healthcare providers, hospitals have left, you have public payers and private payers coming in, and there's no competition there because, strength is always with the public payers. They just don't have the reach. Private payers have the reach. So it's like a beautiful marriage between both to help, cover the entire patient population. So I'm looking forward to it.
Thanks, Rajiv. Any thoughts to that?
No, I agree with what Karen is saying. Again, in my mind, I'm just imagining a 3-year horizon, right? So 3-year horizon, you have a ecosystem leader or the integrator like a Practo, partnered with a ICICI Lombard, and offering a outcome-based treatment, right? So if you have a fever, go to a provider. So your provider is this, you have your lab, you have your medication, and your fee is a fixed amount of 600 rupees or $10, right? So outcome-based model where a payer does not grapple with those complexities. At the same time, it is obviously benefiting the patient, and everybody in the ecosystem is financially rewarded and partnered. So your patient's experience increases significantly by accepting those services. At the same time, everybody as part of the ecosystem is aligned from business model perspective, from a financial reward perspective. So that's how would be an ideal state. So let's hope for that.
Let's hope for that indeed.
Yeah, and Rohit, just this thing. So Rajiv, fully agree on that ecosystem, and you're right. Like like Practo and all coming in, they have their own incentives that they're coming in, so they're happy. But I think finally, what you mentioned earlier, I love that it has to be centered around the patient.
Yes.
So we have 3 types. The way I see it, one is where no data is shared. The patient has no clue about that data. The one that we are talking and we are in right now is where for example, the ecosystem players like Practo, MyDoc, they do share their data. So the patients, when I say share the data, the patient can actually look at their reports and their medications and blah, blah, blah. And, and the third, but it's still silo, right? Because they only have from MyDoc or from Practo, they do not have the rest of the medical records. So it's still in not optimal. The optimal one, when you turn it on its head and say, patient will have access to all data and patient will decide who should view what. Look at it this way. So it's like we did it, right? For COVID vaccination, what did we do? Whether I travel to Canada today or Rajiv comes to Singapore, you still need your vaccination certificate, right? And what is that? That is Rajiv and Karen are able to see their own information, when they were vaccinated, with what were they vaccinated, any COVID episode, and you can travel anywhere in the world. And that's how it should be with healthcare. So we should have access to all our data, whether it's images, whether it's smart wearable data, continuous monitoring, whether it's the EMR, we should have full access. And we decide, today I'm going to meet Practo and I'm going to give them access to this data. And it's possible through blockchain, through FHIR. You can have different players of the ecosystem viewing different parts. But the beauty is that whether Rohit today is doing a podcast in Singapore or tomorrow he's in the US or Canada, he has all his medical records at his fingertip. And whether he needs it anywhere or he just needs to flash it somewhere, he has it. So that is where then the whole patient experience becomes amazing, and with proper privacy and compliance in place. And we've seen that. I loved it when for the COVID vaccine, we could just travel anywhere. I mean, some did have paper still, but it can easily be digitalized as well. So look forward to those days, and probably we might have a different podcast then, Rohit.
That's right, version 3.0. It's interesting hearing this, that for all the time that we've been in this industry, it's always been about health literacy and how health literacy has been either one of the biggest barriers or challenges. And hearing this discussion, it's almost like saying, if digital nativity is not equalized to health literacy, a lot of what we just talked about is going to be a challenge. And this, I think, refers closely to work that WHO, particularly around non-communicable disease, is focused on. And that is fundamentally this sort of inequity in access. So we all know about inequity of access to health and health access and so on, which is clearly an issue still. But the inequity of digital access, a large portion of not just our region, but several parts of the world, populations don't have equitable access to neither the necessary health services nor the bandwidth. And I think, as you've just both been discussing, that sometimes having that bandwidth can make all the difference. It can augment the health experience. Now, how does this then sort of come into play with what we've just touched upon? And do any of these innovations, either in North America, here in Asia, start to maybe look at this as a potential area of focus? Raji, would you want to have a go at
Yeah, sure. No, sure, Rohit. I think this is a very important point, right? You mentioned digital nativity, but on a lighter note, I would want to also add a term here, which I learned recently, which is digital immigrant, where people who are born slightly prior in 1980s and before that, so they have moved into this digital native scheme of things. So when it comes to digital nativity, where we are seeing a hope, at the same time there is a challenge with health equity, especially around digital health equity with the changing scenario post-COVID. Now everyone enjoys a level of literacy and access to digital health, but at the same time there are gaps. Not everybody has access to those resources, not everybody has access to those technology and tools. Now, here is where we need to ask a question, right? Especially from the providers, from in the industry, in the respective places of decision making, whether the technologies today, are they available to support lower technology, like a minimum broadband access? For example, do they work in the offline mode? Because most of the parts of Asia are right now not having that kind of connectivity. The second is, are those tools and technologies, are they linguistically and culturally, can they align to the local nuances? Because the market is so diverse. People are coming from different cultural and linguistic background. Does it also accommodate payment parity? There are out-of-pocket payments. Some people prefer maybe DBS Payla or Paytm. Some people prefer online transfer. So is there payment parity in those digital health technologies and tools? And last but not the least, again, coming to personalized health, are those clinical workflows and treatment pathways aligned to local personal preferences and geographically aligned places? So we need to ask those questions in the industry. Now these are aspects which we need to think when it comes to health equity in the region. Now, when it comes to, I can probably give you some example of how we look at health equity, especially around digital health equity in Canada. Now, of course, the market is at a different maturity stage. The market is differently funded as well. So there might be limited comparison, but the way we are seeing digital health equity and health equity at a broader scale is around three things, right? So from our market perspective, I think health equity is part of our culture. Now, when it comes to any organization, any initiative, health equity and equity as a concept, as a discussion point is absolute must. I think from my experience working in Asia and work coming here, equity is something which is given. Every topic, every discussion, equity will be discussed. So culturally, it is very ingrained. Second is, there are now evaluation organizations that are coming in place, especially in Canada. For example, recently we have set up a Canadian network for digital health evaluation, which is specifically set up to evaluate the various digital health tools that are being implemented in the market around the different asks, of which equity is one of the key asks. So again, if you see, equity is again considered really important, and that's why this organization come in place. And third but not the least is implementation. So any project, be it a large-scale digital health program or a small setup of a tool in a small setup. Implementation also considers a lot around the health equity. Now you can see the number of job postings online where the title says health equity manager or health equity analyst, which are essentially resources and associates who are working on these projects. So you can understand the level of importance that we give to this particular area. And that's how the overall market is shaping up, and that's something which needs to be looked at if any of the other markets in the Asia is also looking at ingraining more equity based aspects within their programs, digital health initiatives, and so on and so forth. So that's something which I see really important for us here.
Thanks.
Yeah.
Erin, what would be your thoughts to that?
So I think there were two questions around there in terms of health equity with technology. I think Rohit, my take is that technology is a leveler, right? Technology does not know who's rich, who's poor, who has not. So my take on that is that it's going to be a leveler and we're going to be better off. But I want to focus a little bit more on the digital health equity and skilling as well. So one of the things that you rightly mentioned in the beginning is that there is a severe skill shortage, right? Because as we get into this whole digitalization thing, can we even pull it off? You have a big ship, but we don't have equipped with good sailors or captain. So one of the things that we've seen, and this is so apt because now because of COVID, you see, it's a chicken and egg, right? So because of COVID, you need to digitalize, and because you need to digitalize, you need the people. But healthcare was already very burdened, and there were very few people. And now with all these, roadblocks in terms of, you can't move, geographical barriers, like you can't go into this country, you can't, lockdown is here, partial lockdown, semi lockdown. People couldn't move, and people, like at least in Singapore, we depend a lot on workers, healthcare workers from outside coming in and helping. So it was I can say, a nightmare. And so one of the asks that we've had from many governments is around skilling. Hey, help to skill up our people so that we can implement these projects. Because many times when you don't have those skills, then tech companies like ours have to come in and step in, right? But the whole idea, the mission of Microsoft is that every organization is going to become a software company, and you've got to have your own skilling. So I want to share a few things that I think Microsoft did really well, and I benefited personally a lot. So we have things like ESI, where we kind of, in a very low cost fashion, we actually help our the people, the workforce in the client's place to skill up. And this is where LinkedIn Learning comes in. We do a lot of learning through that. That's one. The other one is, as what Rajiv rightly said, the people who are also skilled. You see that normally women and girls are the percentages who are in the tech field are much lower. So we have something like Coding for Girls, where we go and encourage them. There's a separate program, we give them projects. So that's to encourage that section of society as well. And the other thing is, like, whatever it might be, imagine if you were to teach me C++, it's going to take ages, right? We don't have the time. So that's where technology comes in and says, hey, can I make it? And I think, Rajiv, you alluded to that, where low code, no code. So we have something like Power Apps, where, it's just like Lego blocks. You just kind of pick and you can make your app. And it's really easy, so much so that even my 12-year-old can quickly make a simple app. So I think that's also where technology can help by simplifying things, pre-building them so that you just put those things together and you have something basic to run with, at least, right? Like, let's say, patient appointment booking. Make a simple app and you have all your data points in. So that's another thing. But lastly, I think a growth mindset, because that is something that I love in Microsoft, is that every day we have to learn. It doesn't matter who you are, you have to learn every day. And there are courses that force you to do it. They're compulsory training, you have to do it. But things change so fast in technology, as well as in healthcare, right? Because you're going to be using the technology to help your clients. And so you're forced to become from a fixed mindset to a growth mindset. I know it all, to I need to learn it all. So that's where you then, irrespective of your age, and I think personally I've benefited a lot, because now every day I have to assign 32 minutes to an hour where I'm just reading up on what's the latest. Could be an area of interest, but you're forced to learn, because a lot of us, whether it's technology or whether it's learning, we stop learning. I don't know about Canada, Rajiv, but in this part of the once you have a job and you're up there, then you relax. So no, that is not the way in Microsoft they push you, and that I think is a good way to kind of skill up yourself. Governments are doing it because, like in Singapore, you have the WSG, we're saying workforce skilling. You're giving them credits and saying take up a course, but it's interesting because everybody will have to have some digital skilling going forward. It's inevitable. Like even in schools now, they're doing coding, but the population in between, not the younger one, but the older one, will have to kind of skill up.
I think hearing this, I'm going to have to tell my son to reconsider his university choices and perhaps get into more of the computer learning than policy. Thank you so much. I think hearing from you both gives not just confidence, but a lot more understanding and the simplification, one can say, of a very complex discussion. As we come up to the hour, this is our, as I said, the beginning of a discussion. This is really something that's meant to create more dialogue, have people think more about these issues, and hopefully help our listeners who are in various different organizations in the academic side, in government, etc., to have a good source, have a way to really just break this down and understand for themselves what it takes to build strategies and programs for personalized health in particular. If I could ask, I guess, as a last leave behind, Rajiv and Karen, that what would be your takeaway hearing this discussion, your top line thoughts? I usually try and say, give it to me in a sentence, but that's okay. We can give it a couple of minutes. It's a complex one to try and do in a minute. But what would be your viewpoint, and what would you think our listeners should take away from this last close to an hour of listening? Rajiv, why don't I start with you?
Yeah, sure. So I will just bring a perspective back to the market, right? Where your Asian market is very heterogeneous. You have developed Asia, you have developing Asia, and you have underdeveloped Asia. And why I say that is because the focus, the priorities of the government, the various stakeholders slightly vary, considering where the market is in terms of the maturity stage. However, because we are living and we will live in a very digital native environment, and we are going to see a lot of growth in technology adoption, I think for me, the 3 points that would be really important for us to create a long-term sustainable healthcare environment ecosystem would be: one is deploy meaningful digital health technologies that will allow to create, clinical, operational, as well as financial value, but at scale. It should not just be an initiative to at a point of care and satisfy the requirement, but it has to be really meaningful digital health technology. The second is, Karen also alluded to this. Think of any initiative with patient in the center. Patient has to be the focal point. Patient has to be the center because that is where the maximum value is. That is where the maximum benefit and outcome and impact is. And last but not the least, all these ecosystem partners have to come together, align on common goals, align on what are the local government's priorities, what are the local regulations, because that is what is going to give them success. So these are my 3 takeaways, and that's how I'm seeing the market shaping up.
Thanks, Rajiv. Karen.
Yeah, so I'll probably take off from where Rajiv left. So you see, regulators are always going to play catch up. So I would, if I can say, leave them behind, because one of the missions that Microsoft also has is to also educate policymakers and explain how technology works. Now, I wouldn't say that technology is perfect, but you need to push the boundaries, right? We never had a Facebook, but look at it now. All of us, the first thing we do when we wake up is to look at, what's been the load. So I would say, take the challenge. Finally, we all want to live longer. We want to live better. And interoperability is going to be the way. There's no way out. Either you do it through FHIR or you do it through blockchain. So my final thoughts are interoperability is what it's going to be. So if people are really scared to say that, it might just bomb, we have very interesting sandbox environments we can build, right? So you pilot an idea, see how it works, You're not ruining your normal day-to-day running. Use sandbox environments, experiment, and see what works beautifully. Because we do see the laggards, we do see the first movers, right? If you look at, we were talking about payers, and we've seen that private payers are first movers. They've already moved away from, oh, I don't want the systems that don't talk to each other. The discussions we nowadays have is, give us API-based services. I want everything to be interoperable. So they're already moving ahead. And I think that's where our public payers should kind of move on and say, hey, let's experiment. If this works well, let's take the next step. And even within the public system, I have seen, those who are movers and shakers, they're willing to take that leap forward. They may fail one time, they're successful 2 times. But I think that's where we need to loosen up a bit and say, the old way of looking at healthcare is over. If we don't let go and move to the next step and use things like, privacy, compliance, and those are all very valid, but we do have technology to take care. And so I think what we need as humanity and community is to take that bold step forward and say, let's experiment. Let's see what's the best way forward. And technology always plays along, right? I mean, when you need something, when there's a gap, technology always finds some solutions or some innovation. And I think that's how healthcare and innovation and technology should go hand in hand.
And on those sage words, we come to the close of this episode. Thank you to all our listeners who've been following and giving some very, I think, important feedback as well. We love hearing from you, and I think that makes all this so much more worthwhile. Again, I'd like to thank our guests today, Rajiv and Karen. Thank you so much for taking time out of your busy schedule and at 2 very different time zones. So thank you for that as well. You can follow us on our RSS and Spotify channels, or you can see us over at www.thevoicesprojectasia.org. We love to hear from you and from all our listeners. And if you have any feedback for our guests at any point in time, do just let us know. It's always great hearing from you. Thank you again, and see you all very soon.